my feelings were like we are quite overwhelmed at this point of time, right? We feel like this is do and die exam for me, do or die, or like what I will do in future if I don't get, good marks in this exam. My friends are getting good rank. They have studied so well. I have wasted my time yet. My feelings were till now, like where the God will take me, or like what happens if I don't get good rank and my partner or whoever I'm studying with get good rank. So all this thing happen with everybody. Okay, this is very, very common in this phase. So just don't get panicked for that, first of all. That is very important. Okay. Apart from that, if you have any second thoughts, कि यार ये पढ़ना है क्या? ये मतलब do we have to refer that source? Do we have to, कोई rapid revision का आ रहा है, उसे करना है, क्या करना है? So always give yourself a benefit of doubt. Watch it. If it's really helpful, then do it. If you think that your time is not getting utilized to the most, then don't do that. All right. So, in a nutshell, the message in last few days from me to you will be just don't get anxious on anything. Okay. I'll just write few things. No anxiety. Because believe in yourself, you have already done so much of hard work. Just keep on doing that same thing and don't, you know, overburden yourself here. You are so precious. I'm saying your mind or your mental strength. I'm saying, when you compare with the others in this phase, you might get stressful. Now, one last point I would like to tell you, whatever questions we are discussing in this presentations, okay, there is very high probability those kind of questions can come in exams. Please don't miss that questions. Okay, don't miss whatever we are seeing as a questions in this discussions, because you will feel in exam definitely everything is around that. Okay, not exactly that type of question, but yes. Okay, because I was also at NB. I have been for the DNB medicine students per se, for the courses and all. We used to do that. So I exactly have a bit of idea that what to expect in these exams. So that's why I'm just helping you all with that. Okay, right? So finally, just revise whatever I give and don't overburden, etc. And stay very humble during examination also. If you get one correct, if you feel that, yeah, now I'm getting one correct, second is also I'm able to make correct. Okay, there is a very high probability that you might get distracted for the easier questions and do mistakes in that. Okay, so try to avoid that. So stay humble. Your goal should be to attempt all the questions with equal sense of responsibility. Okay, right. So that's all. Let's start with the discussion now. Very, very important points. We will quickly go through the hyperthyroidism. In hyperthyroidism, we know we have Graves' disease, we have the thyroid orbitopathy, okay, exophthalmosis and all. Now there are few key things which we're going to discuss. Let's see with the question first. Yes. So as a ritual, we have a question. A 28-year-old woman presents with complaints of weight loss despite increased appetite, palpitation, heat tolerance is there, heat intolerance is there, anxiety is there. Okay, since 2 months. Okay, so what do you expect from this question? On examination, she has tremor, tachycardia, diffusely enlarged non-nodular thyroid gland is there. So see, non-nodular thyroid gland. That means there is a diffusely enlargement. And her eyes appear prominent and she has difficulty with upward gaze. TSH is suppressed. TSH suppressed, that means hyperthyroidism is there. T4, T3 is elevated. And RAIU shows homogeneous increased uptake. So what do you think is the diagnosis? Very easy answer. Yeah, it's Graves' disease. Now, why it's not toxic multinodular goiter? So, if it was toxic multinodular goiter, they would have given you patchy. Okay, they would have given patchy uptake on RAIU scan. Okay, patchy uptake on radioactive iodine scan, RAIU scan. Okay, also on examination, they should have given over here that here it is given diffusely enlarged. In case of toxic multinodular goiter, they would have given nodular thyroid gland was noted, but here it is non-nodular. Okay, so these 2 points very, very important. Now, subacute thyroiditis, you guys know this is post-viral. Okay, this is post-viral. And factitious thyrotoxicosis, it's like very high probability they're not gonna ask this question, but that's after taking certain medications. Okay, after taking amide iron, if you guys remember, okay, amide iron has close mimic with the iodine. So if you give excess of iodine, and there is a high probability that thyroid toxicosis occurs because of the drugs. Okay, so that one drug such is like amide iron, right? Or over iodized salts or frequent intake of salt and all these things are there. Okay, so in a nutshell, Graves is the most common cause of hyperthyroidism. All right, it is common in female, almost 5 to 10 times to male. Okay, so why I have added this point? Why I added this point is you can get this all except type of questions. Okay, that all are true about Graves disease except. So this is more common in female. So very important. This has been asked earlier also. This is more common in female. Majority of the autoimmune disorders, except few vasculitis, are common in mostly female. Okay. Yes. So obviously it has correlation with autoimmune disorders, like you guys know, vitiligo, type 1 diabetes. They have several questions also like this. Okay. Now coming to the pathogenesis, you guys know there are TRAB antibodies or TSH receptor stimulating antibodies. Okay, thyroid stimulating antibodies. TSI or thyroid receptor stimulating antibodies. Okay, TSI or TRAB type of antibodies, don't confuse with the anti-TPO. In exam, you will get confused with the anti-TPO, which is seen in the Hashimoto. Okay, now see, there is one very crucial, or I would say a critical thing that you should know about the Hashimoto's is with Hashimoto, you can have hyperthyroidism and hypothyroidism both. So in exam, if you get a scenario of hyperthyroidism, never like just ignore at the Hashimoto's first. See for the antibodies. If they have anti-TPO antibodies, then it's Hashimoto's. If they have TSI or a trap type of antibodies and all the features of uh, thyroidopsychosis are there, then you can expect Graves disease. Okay. Along with that, you have the orbital fibroblast proliferation causing Graves ophthalmopathy also, right? In ophthalmopathy, you know there are several eye features which you have seen. Okay, Darempel sign are there, and Stellback sign is there. Different types of signs are there. Okay, then pretibial myxedema is also one of the feature that can be seen because of the glycosaminoglycans and fibroblast activation. All right. Apart from that, features of hyperthyroidism you guys know already, but I will just highlight few. In eye, exophthalmosis and orbit due to orbital inflammation is very important. Pretibial ectoderma in the and thyroid examination shows the diffuse goiter. Apart from that, all the features of hyperthyroidism, palpitations, sinus tachycardia, atrial fibrillation, tremor, etc. Okay, anxiety, insomnia, all are there. Right? Talking to labs now, T3, T4 will be increased, TSH will go down because of the feedback mechanism. It's very easy. Radioactive iodine scan is very important. You expect at least one question on this in your exam. Okay, at least one question I'm saying. Very important. Okay, so if you get diffuse homogeneous uptake, okay, versus patchy uptake in toxic monotetragotal, that then you suspect for the Graves disease. All right, for treatment, start with the beta blockers. Antithyroid drugs are the drug of choice. They are treatment of choice in case of hyperthyroidism patient. Very important. Okay, for your exam, if they ask what is the first line treatment would you do for symptomatic relief for this patient, so that would be beta blocker. But if they ask what is the gold standard, or like what is the best treatment, what is the next best step, or even if they ask like what is the definitive management in this case, that would be methimazole or propylthiouracil. Now, you know propylthiouracil is given in the pregnancy. Methimazole is not given in the pregnancy because of the risk of the choanal atresia, aplasia cutis. Okay, these are the side effects of the methimazole. I hope you guys already know that from the pharmacology, right? After we have a radioactive iodine ablation. So this is also recommended in non-pregnant adults. Okay, and if there is a history of recurrent disease only. So finally, surgery. So this is very important. In they ask about what would you do in this case. So large goiter if it is there, or their pregnant female is there, or ophthalmopathy is there, or radioactive iodine refusal is there. In this case, we do for the surgery. Okay, and this point I've already explained. Methimazole contraindicated in the first trimester, and radioactive iodine is contraindicated in the pregnancy and the lactation also. Okay, so complications of thyroid, Graves, we already discussed thyroid storm, atrial fibrillation, osteoporosis from chronic hypothyroidism. This is a very important point. Huh? They will ask in your exam, which of the following is the not a complication of Graves disease. They will give you the history of typical Graves disease, and now they will give you all the options that thyroid storm, atrial fibrillation, osteoporosis, or this might be something else. Okay. So they might be giving some feature of hypothyroidism, like Voltman sign or delayed thyroid or delayed reflex, muscle reflex. Then you should remember osteoporosis can be seen in case of thyroidism. Okay, because of the increased turnover of the bones. That's the logic behind that, right? So, key differentiator we have already discussed. TMG, that is toxic multinodular goiter. Older patients, nodular, and RAIU will be patchy. Subaracute thyroiditis, it is painful. It's very, very important. It's painful. And most of the times there is a history of viral fever or viral infection. Then factitious. So as I said, in this case, low RAIU uptake will be there because already gland is active and it occurs because of the suppressed thyroglobulin, which occurs in case of drug intake like amiodarone or iodinized other drugs. Okay. Then finally, struma ovary. It is, you guys know, it's kind of ectopic ovary. Ectopic thyroid tissue seen in the ovary. Okay. This is ectopic thyroid tissue seen in the ovary in which there is a low radioiodine uptake and thyroid gland per se is normal in this case. You will see patient is having thyroid features, but gland is normal and RAIU uptake is also not there. Then in this aspect, if pregnant female is there, or sorry, if like reproductive age female is there, then you suspect struma ovary also. So this can be something which you have to be really, really cautious while solving the questions. Okay, so these are some one-liners. Most common cause of hyperthyroidism in young female is Graves' disease. Most specific test is TRAB. We already discussed this. Graves' ophthalmopathy is autoimmune and independent of T3, T4 levels. So this question is commonly asked also. Which of the following statement is wrong about Graves' ophthalmopathy? So Graves' ophthalmopathy is not dependent on the thyroid disease progression or T3, T4 levels. Very, very important. Okay, radioactive, we have already discussed. In RAIU, diffuse homogeneous uptake will be there. And long-term treatment is anti-thyroid drug first and then radioactive. Okay. So I hope you understood the importance of the Graves' disease. Now let's move on to the next topic. Okay. So we already solved this question. Multiple patchy areas of increased uptake is there. What would you suggest? What do you suspect in this case? Yes. Yes. Correct. It's very easy, right? We just covered this thing. Yeah. Sorry. Okay, we just covered this thing. Okay, so same thing again. I'm not going into detail this time because you guys know increased diffuse uptake, Graves' disease. Patchy uptake, toxic multinodular goiter. Single hot nodule, toxic adenoma. Now, this is very, very important for you. Okay, here you will get the hot nodule. Okay, hot nodule means different colored nodule will be there. Okay, then very low or absent uptake in case of subacute thyroiditis, factitious thyroid. In all these cases, basically you have the reduced uptake or low uptake will be there. Okay, right. Yes. So finally, what is RAIU or non-RAIU based workup? Okay, so if they can ask you, so it's just same, the other names they have kept. Okay, so RAIU will be increased uptake in case of Graves, toxic multinodular goiter, toxic adenoma, TSH secreting pituitary adenoma, and early iodide-induced thyrotoxicosis. Only thing you should remember is in case of subacute thyroiditis, your uptake is not increased. That's very, very important point. Okay, so if you guys remember that image, they give like this thyroid image, right? They tend to give you this kind of thyroid image where the patch, they will show single patch like this. So single patch is like this. That means there is a increased uptake at one point. So it is toxic adenoma. All right. If the whole gland goes like this, right, in the same color like this, that means there is a diffuse increase in uptake. So that occurs in case of Graves' disease. All right. If whole gland is like this white, no uptake increased, then you can suspect other causes, either struma, ovary, or something, depending on the history. Okay, right. Properly, if you draw, it's okay. Okay, this is the nose and all this type of gland is there, right? Like walnut, what we see. Okay. Coming to this again, yeah, these are some one-liners. Diffuse uptake, Graves. Patchy, toxic multinodular goiter. Increased thyroglobulin, thyroiditis. Decreased thyroglobulin. Okay, so this is very, very important again. In thyroiditis, subacute thyroiditis, thyroglobulin you have to check, that will be increased, whereas in case of factitious thyrotoxicosis, your thyroglobulin will go down. Okay, so you can expect this type of question. They can ask in depth about these topics. Okay, then RAIU is contraindicated in pregnancy and lactation, and thyroids can give structural nodularity. Okay, yes. So coming to the next topic now, about thyroid ophthalmopathy. This is the topic. A 33-year-old woman with known Graves, presents with double vision, gritty eyes, upper eyelid retraction. She is a smoker and recently undergone radioactive iodine therapy. On examination, she has bilateral proptosis, restricted extraocular muscles. So, you guys know what would be the best treatment for her. She is having thyroid ophthalmopathy. Oh, sorry. Audio is not that good, right? No, 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 no. Why immediate orbital decompression therapy? Steroids. Okay, we go ahead with the steroids. If patient is having symptoms like that, mostly go for the steroids. Okay, yes, right. So thyroid ophthalmopathy can be seen in 25 to 50% patient of Graves' disease, mostly in females, and also can be seen in males, but it is severe. Okay, and in case of pathogenesis, we know it occurs because of the increase in the GAGs, that is glycosamine glycans, and the autoimmune cross reactivity is the mechanism for that. Okay, occurs because of muscle and fat expansion. Now, talking about the clinical features, proptosis is most common feature if they ask about. Then lead retraction sign is also, if they ask about which sign is the most common. So this Dalrymple sign, okay, where upper eyelid is pulled back. That's Dalrymple sign, okay. Apart from that, diplopia can be seen, conjunctival chemosis, that means red eyes, photophobia, dry eyes, and compressive optic neuropathy can also be seen. Okay, for investigations, mostly you go for the examination only, physical examination is best. Talking about the treatment part, as we can see, if severe and optic neuropathy is there, then go for the urgent orbital decompression therapy. All right. In our patient, what we have, okay, just let's see. See, orbital, this neuropathy is there, double vision is there. Okay, double vision and all these features suggestive of neuropathy. That's why the answer yes was correct. Immediate orbital decompression surgery. If these were not there, then you would have done the steroids only. Okay. I hope I am able to justify. Right? If moderate moderate is proptosis diplopia only. Yes, sorry for this. Moderate is proptosis and diplopia. And in case of orbital neuropathy, the blindness feature will be there. Okay. So if they talk about like vision loss is there. Okay. I'm really sorry for this. So if vision loss is there, then you have to do decompression surgery. But in case of proptosis diplopia, only IV steroids will suffice. Okay, apart from that, smoking cessation should be advised. Definitive thyroid therapy can help. Okay, but radioactive iodine is contraindicated. Okay, very, very important point. RAU is contraindicated. And teprotumumab is a new drug. Okay, this has been approved for, it is IGF-1R antibody approved for the thyroid. Okay, particularly in patients of ophthalmopathy. Okay, teprotumumab. So it can be asked. I hope you must have read that in your pharmac discussions also. Okay. Somebody said, sir, please share the PDF of the group after the class. Yes, yes, sure, sure, sure. Okay, I will share. This is very important here, guys. Please focus, huh? And ask your friends also if they want to join. Anyways, so complication of this after thyroid ophthalmopathy, exposure keratopathy can occur, optic neuropathy can occur, that can cause permanent vision loss, disfigurement can occur. Okay. Anyways, not going into the much of details, and this is the summary of what we just discussed. Few one-liner I've added again, that which is the extraocular muscle most commonly involved, etc., etc. Let's see this. Most common sign, lead retraction. Okay, most common ocular finding, right? Most common extraocular muscle involved is inferior rectus. MRI sign, we will have the muscle belly enlargement, sparing the tendinous insertion. IV methylprednisolone is preferred over oral steroids for moderate to severe disease. Smoking is the strongest modifiable risk factors, very, very important. And radioactive iodine versus the orbitopathy. Right? Now, next case is your Myxedema coma, which is again complication of hypothyroidism. Okay, so let's see this question now. A 67-year-old woman is brought to emergency department in winter and with altered mental status. Now, winter is also one more important point that you should note over here, because hypothyroidism can get aggravated in winter because patient is already cold and the weather is also cold. Everything gets bad. So then hypothermia, cold temperature is 32 degrees Celsius. Then hypotension, bradycardia is there. Okay, all these are features suggestive of hypothyroidism. And she's also has the issue of osteomatothyroiditis. So as I said, in osteomato hypothyroidism to hyperthyroidism, anything can be seen. With poor medication adherence, on examination, she is lethargic, dry skin, and periorbital puffiness is also there. Sodium is low, 122. That may be a cause that she has an altered mental status. Okay, so in exam, you get confused with this. Blood glucose is 54. That means hypoglycemia can also be there. TSH is 95. T4 is undetectable. That says that hypothyroidism very, very prominent in this patient. Okay, cortisol is still awaited. So what is the most appropriate immediate next step in this case? What do you say, guys? Yes. Yes, everybody attempt this. Uh-huh. Cortisol is pending, huh? Okay, let's see. Okay, let's see. So this was the case scenario. It occurs in case of hypothyroidism. It's highly fatal. 30 to 60% patient will have that. Yeah. And elderly woman is most commonly affected in this case, triggered by the cold exposure, as I said, infections, MI, any kind of stress to the body, basically. Pathogenesis, it occurs because of severe deficiency of the thyroid hormone. Okay. And it is compounded by hypoventilation, hyponatremia, hypoglycemia, adrenal insufficiency. All of this thing, yeah. Okay. Hypoventilation, hyponatremia, hypoglycemia, and adrenal insufficiency all can be there together. But the important point over here is to remember the investigation feature and the treatment feature. Okay. These are something which is important. But apart from that, yes, you can have CNS depression, impaired thermoregulation, and these all features will be there. TSH is high. Okay. All the features of hypothermia exactly will be there in case of this patient with the hypothyroidism. Then expected investigations, obviously, TSH will be high, T3, T4 will be low because this is complication of hypothyroidism. ECG might show what wave can be seen in this patient. You guys know that wave? Yes. You guys don't know that ECG wave? Osborne wave. Very good, Pranay. Yeah, Osborne wave. Very easy also question. So it is not seen in the myxedema, coma, or hypothyroidism. It is seen because of the hypothermia. Okay. So now caution management. First and very, very important, rewarm aggressively is not recommended. Okay. Why? Because it can cause vasodilation and the cardiovascular collapse. Because a patient is already in the shock and you are just giving rewarming, that means peripheral vasodilation will occur and cardiovascular collapse can occur. Okay, so first let patient's temperature get better. I mean, first let patient's thyroid and resuscitation get better, and then we will give hydrocortisone, and then we can think of rewarming. Okay, so always give hydrocortisone before T4 to prevent adrenal crisis in this patient. So we should have given the hydrocort first. So treatment part, levothyroxine LT, that is T4, levothyroxine 20 to 400 mcg, loading bolus has to be given. Then IV leothyroidine has to be given. It is optional, but it is mostly given. Okay, 10 mcg every 8 hourly can be given. Then hydrocort is very, very important. Followed by supportive care, warm blankets, etc. Passive rewarming, not active rewarming. Okay, remember passive rewarming is recommended. Then glucose saline oxygenation. And if there is an infection, treat that. And if there is any ventilatory support needed, then manage that. Okay, so I hope you understood. And this is very important. T3 has a quicker onset, but has a higher risk of arrhythmias. That's why T3 is preserved for the severe cases. Okay, we start with the T4 only as a injections, 200 to 400 mcg loading bolus. Right? So most specific features, hypothermia, bradycardia. Okay. Most common precipitating factors, infection or cold exposure. First treatment is hydrocort. Okay, that was the answer in our patient. Then levothyroxine and TSH is very high. 3T, 3T4 is undetectable and mortality again very high. Right? Now coming to the multiple endocrine neoplasia. First answer this question and then we will move ahead. Yes. So 35-year-old man presents with recurrent epigastric pain, chronic diarrhea is there, weight loss is there. So that means there is something pancreatic tumor is there, either gastronoma, etc., etc. Can be anything. We will see that later. Then endoscopy reveals multiple duodenal ulcers also, mostly gastrinoma, that means. Okay, because increase in the gastrin. They have also given increase the gastrin levels. Calcium is also 11.4. That means parathyroid is also involved. MRI brain also shows 5 mm cellular lesion. That means pituitary is also involved. Then what is the most likely diagnosis? 3 P's are involved. Yes, very easy. Men one, very nice, very good. I know it's easy, but in exam it won't be that easy. Okay, it won't be that easy. I've just kept it easy so that your morale gets up as we go ahead in the lecture. Okay. Yes. So, yes, it is autosomal dominant disorder. We have discussed in the last time also. Presence in young adult. Okay. May present with kidney stone, refractory ulcers, galactorrhea, anything. And mutation is in the 11q13 gene. Okay. MEN1 gene that is present on the 11q13. It is a tumor suppressor gene, basically. If there is a loss of those both alleles, there can be tumor formation. Okay. If there is a loss of alleles, either of the alleles or both alleles mostly, there is a tumor formation. And it is inherited by the autosomal dominant as we discussed. Okay. Now, tumor type in parathyroid, primary hyperthyroidism is the most common, and it is overall most common feature of the MEN1 syndrome, causing hypercalcemia in your patient. Then pancreatic neuroendocrine tumor, in which second most common, it is overall second most common. Okay, PAR-PAN-PEAT, what we remember, right? If you guys remember, PAR-PAN-PEAT. Okay, so parathyroid, pancreatic, mostly you have gastrinoma, which is the commonest. Then pituitary adenomas, in which most common is prolactinoma. This is very, very important topic, huh, guys. Please pay very close attention to this. Okay, so parathyroid most common, second most common gastrinoma. In pancreatic, the gastrinoma is most common, and pituitary galactorrhea is the most common. Okay, lacto drop or galactorrhea. Okay, because of the prolactinoma. What they are writing? Somebody is writing something. Okay, there is something doubt or something, I guess. With the question, they had doubt. Yeah. Meant to A, meant to be medullary thyroid carcinoma, mucosal neuromas, all those features they would have given. Zollinger's lesion, pituitary and pancreas is not involved, right? Only gastric acid will be increased. Okay. Right. So I hope you got it. Okay. Anyways, let's move ahead. Calcium will be high because of the parathyroid. GI features can be there, multiple duodenal ulcers because of the gastrinoma. Neurologically, you can have bitemporal hemianopia. Okay, family history may have obviously there is a parathyroidectomy history will be there. Okay, hyperparathyroidism or any parathyroid malignancy as well. Okay, so for screening, we do parathyroid test, gastrinoma, insulinoma, prolactinoma, genetic testing. Okay, finally, coming to treatment, usually PPI will help, prolactinoma, cabergoline helps. We have already discussed this stuff. Okay, so that's it for the MEN1 syndrome, right? So most common tumor in MEN1 is parathyroid adenoma. Most common pancreatic is gastrinoma. Most common pituitary is prolactinoma. And genetic mutation is meninge chromosome 11q13. Okay, 11q13. 1113. Please remember this 11q13. Okay. Now, parathyroid usually presents with stones before ulcers. Okay. And main one does not involve the medullary thyroid carcinoma or the mucosal neuromas, which is involved in case of MEN 2A, MEN 2B. Okay. So here is the difference between MEN 2A, MEN 2B also. So in MEN 2A, red gene is involved, red proton gene is involved. Okay. It is also autosomal dominant. It is also red and it is also autosomal dominant. Now, important thing is here medullary thyroid carcinoma is present. Often the first manifestation. Here also it is earlier. Medullary thyroid carcinoma is seen in the both of them. Pheochromocytoma is present in both of them in 50% of the cases. Talking about the parathyroid hyperplasia. Okay, it is absent in MEN 2B. Okay. Right. And in case of MEN 2A, you can have parathyroid hyperplasia also. Okay. Yeah. So, yes. All right. So I hope you understood this parathyroid hyperplasia. Why it is not seen in the MEN 2B, because obviously it's genetic feature, but why we don't have to click that option, and we understood that. Now coming to the mucosal neuromas, skin features, marfanoid habitus will be more in case of MEN 2B. Okay. And finally, coming to the onset of medullary thyroid carcinoma, here it will be early childhood and meant to be are the highly aggressive people. Okay. Yes. So just remember like that, to be great person or to be great person, you don't get once you are great, or to be is great, or you can say highly aggressive. Okay, I'm just creating a mnemonic for that. Most of the times you lack pyar or love. Okay, you lack pyar or par, what we can say that. I'm just trying to simplify it for you so that when you go in the exam, you should not get confused again after whenever I'm teaching you that much. All right. So to be great, that means to be very aggressive, you have to lack power in life. That's just a, very boring or maybe very mediocre mnemonic, but I hope it helps you to remember. All right. So lack power, that means you don't have parathyroid hyperplasia in case of men to be. Okay. Right. So men to a 2Ps, that is Pheochromocytoma, parathyroid is involved. In men to be 1P plus 2 weights. Okay, so that 1P is Pheochromocytoma and 2 weights is puff lips and marfanoid habitus. Okay, so I hope you understood. 2B has many features, just parathyroid is not there. Very, very important. Right, so coming to the Cushing syndrome now, we've already discussed Cushing's, but we will just quickly go through that. Okay, Cushing's, Addison's, cons. Then we have parathyroid, pseudo hypoparathyroid, hypoparathyroid, and obesity is there, osteoporosis, calcium is also there, hypercalcemia. Okay, so these few things we'll quickly discuss. Right. So let's try to solve this question, please. 28-year-old woman is there, progressive weight gain is there, facial rounding, easy bruising. All these features suggest you have already Cushing syndrome, no doubt about that. So she has new onset hypertension, proximal muscle weakness is there, and she has purple abdominal striae and all this because of the stretch marks. When they check the urinary cortisol as the first step of screening, it is more than 4 times normal. And overnight 100 dexamethasone suppression test is 9.2, that is not suppressed, and ACTH is elevated. Okay, so it is ACTH dependent. And when they did the DEXA suppression test, your ACTH or cortisol is not suppressed. MRI pituitary, no definite lesion. So what is the next best step in case? You guys know already. Yes? Anyone? Correct. Okay, mostly we will rule out the other cause. Okay, adrenal per se, adrenal, this is not looking like a secondary because see, the ACTH is elevated. If it is adrenal cause, most of the times your ACTH won't be elevated. So in this case now, we have two options. Yeah, correct. Okay, high dose dexamethasone suppression test. But first, we will do the high dose dexamethasone suppression test. I think last time also we discussed this question. So once we do the high dose dexamethasone suppression test, if it is really pituitary, you will see again suppression. And if you confirm that, then you know. All right. If it's pituitary, there will be suppression. If it's ectopic, there will be no suppression. All right. So we have already discussed question. So I'm just going into the investigation diagnostic algorithm. Yeah. So first we do the 1 mg dexamethasone test. Failure to suppress cortisol if it's more than 1.8, that means failure to suppress is there. Then step 2 is to check measure ACTH. If ACTH is high or normal, then ACTH is dependent. Then proceed to the source workup. The source workup can be done by the dexamethasone, that is high dose suppression test. Okay, that is source localization. Okay, so first we did the source confirmation. Now we do the source localization. So after giving high dose dexa, if the suppression is there, then it's a pituitary cause. If no suppression is there, that means ectopic cause is there. Okay, also we can do CRS stimulation. Then if it is increased, that means pituitary cause is there. If it is not increased, that means ectopic cause is there. Because we are giving corticotropin releasing hormone, which is produced by the hypothalamus. And finally, inferior petrosal sinus sampling can be done if you want to confirm again from the pituitary and the ectopic source. Okay. Finally, ACT is independent tumor. We go for the CT or MRI adrenals, suspecting the adrenal cause. Any doubts in this? I hope you understood. I hope you are understanding. Okay. So coming to this, Cushing's disease, transphenodal surgery we do. Okay, as the treatment. What was in the case of prolactinoma? Yes. What is the first treatment we do in the prolactinoma? Yeah, cavagolin. Okay, drugs basically, drugs, medical management. Very good. All right. So after this, we will go for the next question. Yes. 38-year-old man presents with fatigue, weight loss, craving for salt. So craving for salt is feature of primary or secondary additions. I've discussed that already in the first lecture itself. Yes, craving for salt craving is typically seen if there is a mineralocorticoid deficiency. So where do we see it? In primary adrenal or secondary adrenal insufficiency? No, not in secondary. Yes. Okay. Right. So let's see that question now. Patient is having fatigue, weight loss, salt craving is there. So that means adrenal insufficiency is there. Also darkening of our skin is there because of the ACTH increase and over the knuckles, oral mucosa. BP 86 by 60 millimeters of mercury is there. And potassium is 5.6, slightly higher. Sodium is also lower. Okay. Fasting glucose is very low. Cortisol is 2.1. ACTH is 980. Okay. So if they check anti-21 hydroxylase antibodies, those are also positive. So this has to be the Addison's disease, and particularly considering the patient's ACTH level and all, it looks like the secondary. Okay. So it is mostly like life-threatening condition. That's okay. Yeah, here are the features. So your cortisol will go down, aldosterone will go down, androgens will go down. Okay. And secondary, in case of secondary adrenal insufficiency, as we can see here, ACTH or pituitary problem is there and decrease in the cortisol. Okay, that is at the first place in the your secondary adrenal insufficiency. This of primary adrenal insufficiency, which is our case in this patient, leads to increase in the ACTH level. That means the adrenal glands are primarily at the fault. Okay, so adrenal gland is at primarily at the fault. Okay, so that's why you can see because of the increase in the ACTH, raised ACTH, your patient will have skin hyperpigmentation, hyponatremia, hyperkalemia, and because of the reduction in the aldosterone or mineralocorticoids, you will have the salt cravings. Okay. All right. So the answer was primary adrenal insufficiency, not secondary. In secondary, you will only have the decrease in the cortisol. Right. Finally, aldosterone, if it is normal, though no pigmentation, but hyperkalemia can be seen because it is salt, preserving type of hormone. Salt and water retention is done by the aldosterone, right? You guys know that. Now, coming to the investigations and treatments. Obviously, in investigations, you guys know all these features will be there of the reduction in the cortisol or all the hormones. Okay, cortisol or the aldosterone. Now, treatment, investigation first before treatment. Your ATM cortisol level will be low. Plasma ACTH level, if it is high, it is primary. If it is low, it is secondary. Okay. Yes. Now, ACTH stimulation test, also called a snack test. It is when we give that, there is a no rise in case of cortisol in Addison's disease. Okay. So finally, anti-21 alpha hydroxylase or anti-21 hydroxylase antibody, they are positive in case of autoimmune Addison's. Okay. CT adrenals will have small autoimmune and calcified enlarged tubule. Then that would be the cause, if most common cause if they ask about Addison's disease. Okay. So initially they used to think that because of the autoimmune condition, but now tuberculosis is considered as one of the commonest cause in India also. Okay. So treatment, first give the hydrocortisone, obviously, then every 8 hourly, normal saline 5% dextrose, and treatment and the replacement of the glucocorticoid, mineralocorticoid is recommended. Mineralocorticoid recommended is not, mineralocorticoid replacement is not recommended in case of secondary. Okay, not needed in case of secondary, only for primary Addison's. Okay, right. Yes. So most common cause of Addison's worldwide is tuberculosis. Most common in developed nations is autoimmune, hallmark triad, hyponatremia, hyperkalemia, hypertension. All right. Diagnostic test is 8 cortisol. Confirmatory is ACTH stimulation test. As I mentioned, whenever you have any hormone is low, you do the stimulation test. When any hormone is high, you do the suppression test. Like in case of questions, we did suppression test. Here we are doing stimulation test. It's a stimulation test. Then treatment in crisis, IV hydrocortisone saline, glucose we have to give. Hydrocortisone plus photocortisone can be given for maintenance. Okay. And remember, hyperpigmentation seen only in primary, not in secondary adrenal insufficiency. Right. I've covered this point again and again. Please no make any mistake. Okay. When you're solving any questions based on that. Now, coming to the very important topic, that is pheochromocytoma. Okay. You guys know why it occurs, pheochromocytoma. Right. So answer already they have given over here. The important triad of pheochromocytoma, right? Headache is there, palpitation is there, and sweating is also there, right? Sweating is also there. Okay. Headache, palpitation, and sweating. Right. So pheochromocytoma, classically headache, sweating, and palpitation will be there. And very important, paroxysmal hypertension. Okay, paroxysmal or sustained severe hypertension also can be seen. Okay. And when we do the labs, the plasma-free metanephrines and 24-hour urinary VMAs will be positive. Okay, that will be high. Genetic association can be seen in case of men to A, men to B, VHL, and neurofibromatosis. So this question can be asked. Okay, this can be asked, like which of the following is the association, genetic association of the pheochromocytoma? So men to A is there, men to B is there, men 1 is not there. Okay, so that was PAR PAN-PIT. Now pheochromocytoma. Okay, I hope you understood this. Right? Triggers for pheochromocytoma: exercise, stress, surgery, food, drugs, chromaffin cells. Okay, all these things. So these are the common confuser in the exams. All right. Pheochromocytoma, thyroid storm, panic attack, hypertensive emergencies. So very important. In case of hypertensive emergencies, sustained very high blood pressure will be there, and patient will have features of end organ damage will be there. Okay, end organ damage, that means features of AKI will be there, retinopathy will be there, or LVH will be there. So, okay, so all these features can be there in these patients. Okay, now coming to the panic attack. So in panic attack also you can have high blood pressure, tachycardia, sweating, all those features will be there. But fever, okay, fever which is present in the thyroid, here it is not present. And also the sweating, okay, here the sweating is profuse, very high, but here the mild sweating is there. Okay, just you will feel that mild sweating is there. In case of pheochromocytoma, I had seen one patient recently of pheochromocytoma. Actually, the patient came through the online portal to me, and they said that, sir, I have profuse sweating. Profuse in the sense is even without doing any activity, my bedsheet gets wet. Okay, so that suggests pheochromocytoma. Severe hypertension, paroxysmal plus sustained. Okay, so in this case, use alpha blockers first. Here you can use the beta blockers directly, but here alpha blockers are first given. Okay, why they are given? Because of the priming of the vessels is required. That means if you directly give the beta blockers, unopposed olfaction can happen. But if you give alpha blockers first on the vessels, so alpha blocker will cause those vasodilation, then beta blocker will cause those vasodilation, and the patient's blood pressure gets back to normal. That is your mechanism. Also, for pheochromocytoma patient, if you are planning for surgeries, etc., then also it can. Okay. Yes. Are we going good? Speed is good. I hope you are able to revise quickly with me. Yes. So metanephrine is the most sensitive investigation, and 24-hour urinary metanephrine. Okay, free metanephrine is the sensitive, but 24-hour urinary metanephrines are something which are specific. Okay, so finally, you also have clonidine suppression test that probably won't be testing in your exam. CT, MRI, MIBG can be asked for NEET super specialty student, not for NEET PG students. Okay, so the simple logic: phenoxybenzamine given first, non-selective alpha blocker, and after alpha blockade, you have to give beta blocker, right? And finally, surgery is the definitive cure. If you have any tumor, etc., then surgery has to be done. Okay, then yes, so we have already discussed this, right? So complications of unrecognized pheochromocytoma, crisis can happen, edema can happen, stroke, MI, catecholamine-induced cardiac arrest, and these are all tricky. Completion, that's for just complication, completion. So focus on this. Classic triad, palpation, headache, sweating. We are discussing about pheo, right? Most sensitive, plasma-free metanephrines. All right. Then first step before surgery, phenoxybenzamine. Benjamin. Then never give beta blocker before alpha blocker. We have discussed this point. Mental we also discussed this. Okay, middle thyroid carcinoma, pheochromocytoma, parathyroid. And then if you guys remember, what was not there in 2B? Who is not meant to be? Which organ is not involved in the meant to be? Yes, very good. Yeah, yeah. Yeah, okay. All right. This, no, not pancreas, parathyroid. All right. Yes. Okay, so very good. So rule out pheochromocytoma before adrenal biopsy. Okay, else may trigger the crisis. Then rule out before surgery in medullothyroid carcinoma or neuroendocrine syndromes. Coming to the next now, that is your hyperaldosteronism. So what is the next best step in the management? They have asked next best step in the management. Let's see, 42-year-old woman with normal new onset hypertension, muscle weakness is there. Her BP is 164/96 and potassium is 2.8. ABG shows metabolic alkalosis. She is not on diuretics. Renin is suppressed, aldosterone level is elevated. So what is the next best step in this management? Anybody? See, there is a hypodense nodule also in the left adrenal gland. Okay, you're thinking of spironolactone trial in this patient. Okay, that's also a good one. Let's see. Okay, we'll discuss quickly. All right. So this is primary hyperaldosteronism, Conn syndrome, caused by basically other cause for the endocrine. Very good. Endocrine hypertension occurs in 5 to 10% of all hypertensive patients and often missed unless hypokalemia prompts workup. Okay, so if hypokalemia is there, then only we do the workup. So the differentiation, let's see now. In case of primary, your aldosterone will be high, renin will be low, and adrenal adenoma or any hyperplasia can be seen. In secondary causes, aldosterone is high, renin is high, and your RAS or adrenal stenosis CHF can be the causes of these features. Okay, so I hope you understood when do we get the primary hyperaldosteronism and the secondary. So primary is mostly adrenal adenoma or hyperplasia, and secondary in case of non-adrenal causes like adrenal stenosis or even congestive heart failure. Okay, so apparent mineralocorticoid excess like Lidl can also have decreased aldosterone and no renin. Okay, with inact mutation. Okay, so very important features. This is the apparent mineralocorticoid excess. That means patient does not have any other thing, just apparent this mineralocorticoid excess is there. Okay, so finally coming to the clinical features of this, BP will be resistant because of the hyperaldosteronism. As I said, it is salt and water retention occurs because of this. Then decrease in hypokalemia because of decrease in potassium, and decrease in potassium causes hypokalemia, even cramps and weakness. Alkalosis can happen, sodium may go low, and edema can be seen. Okay, mostly salt and water retention is there. Sodium is high or normal, not low. Right, screening test, aldosterone ratio, ARR ratio is very important. If ARR is more than 20, it's just primary hyperaldosteronism. Also very important. Okay, aldosterone high plus renin low, that is cons. Both high secondary and both low lead. Right, so saline suppression, aldosterone stays high, autonomic production cannot. Right, finally let's check localization. So CT MRI will help us to get the adenoma, and adrenal when sampling can be done. Okay, gold standard to localize the unilateral versus bilateral. So finally, treatment, unilateral adenoma, laparoscopic adrenalectomy. Obviously, adrenal has to be removed. Bilateral, MR antagonist can be given. Okay, mineralocorticoid receptor antagonist can be given. Finally, hypokalemia correction, potassium supplements can be given. So these are some important DDs that can go close with this. As we can see, renal stenosis is there. There also you can see hypertension. In Liddle syndrome also, apparent mineralocorticoid excess is there, so that your renin is not low and aldosterone is also not. Okay, aldosterone is high in case of Conn's syndrome, what we just discussed. So NEET PG-INR basis questions. Primary hyperaldosteronism, if they ask about the most common cause, it's bilateral adrenal hyperplasia. Most common surgical cause, aldosterone producing adenoma. Then screening test, ARR, confirmatory test is saline suppression test, and adrenal when supplying is the localizing test. We already discussed that. And best drug is spironolactone epinephrine, and in cons, sodium is normal, potassium low or no edema. All right. So that's all. That's all about today's discussion, guys. I will share the video of diabetes, and then calcium metabolism and obesity. This 3 point, I will separately share the recorded video. Okay. I'm getting some call from the one of the emergencies where I work. So we will deal that first. And I hope we were able to discuss few things today. Now these 4 topics are left. 3 topics are left only, for which I will give you the recorded session. Okay, or we can take it tomorrow. Okay, guys. So I hope you enjoyed the session. We'll regularly continue this. Don't worry, it's my promise. Before 4th of the next month, we had this three days delay. So before your 3rd of June, I will complete entire medicine for you. Also with the notes. Okay, notes I can share today only. No issues. Okay, just give me till 3rd or 4th of June, and then you have like 10 days to revise medicine in that. Okay. अरे स्पीड अभी स्लो रखेंगे तो होगा नहीं ना फटाफट ज्यादा सिलेबस ऑलराइट वी आर जस्ट रिवाइजिंग द स्टफ दैट्स व्हाई आई हैव kept the speed high. See, if I am explaining the basic concept अभी से start अगर किया है right, then it would have been justified that I am keeping it slow, but for this I have to speak with that speed, so that we can cover the like multiple things. All right, Vinod, yes, so you can understand. We know so this is for NEET PG students, all right? This is not for someone who has already passed MD. So no issues. You can attend other sessions. We take different class for the post MD people. OPD class is there, as well as Harrison based classes are there for PGs. Then you can take those. Okay. So this is like NEET PG revision. So we are covering majority of things. Anyways, guys, thank you so much for connecting. We will meet tomorrow again at same time, 8 p.m. Or meanwhile, if you want, I can give the recorded session of these 4 things. Okay. Okay, guys. Then bye. Good night.